Perfect! Since you're preparing for the PEBC qualifying exam part 1, I'll create medium to hard difficulty MCQs directly inspired by the content of your uploaded book, RX Files 9th edition. I'll also give detailed explanations for each question in PEBC exam style. Here's the first set of 10 MCQs, cardiology and endocrinology focus. PEBC style MCQs from RX Files 9th edition. Q1. Which antihypertensive is considered first line in a patient with diabetes and proteinuria according to RX Files recommendations? A. Amlodipine, B. Hydrochlorothiazide, C. Ramipril, D. Mitoprolol, E. Doxazocin. Answer. C. Ramipril. Explanation. ACE inhibitors like Ramipril are first line for patients with diabetes and renal involvement proteinuria as they reduce progression of nephropathy and cardiovascular risk. CCBs and thiazides are alternatives but not superior in this scenario. Q2. Which of the following beta blockers has mortality benefit in heart failure based on landmark trials? A. Atenolol, B. Metoprolol succinate, C. Propranolol, D. Nadolol, E. Sotalol. Answer. B. Metoprolol succinate. Explanation. Evidence-based beta blockers for heart failure include bisoprolol, carvedilol, and metoprolol succinate. Atenolol and propranolol lack strong HF mortality data. Which adverse effect is most strongly associated with ACE inhibitors but not ARBs? A. Hyperkalemia, B. Dry cough, C. Angioedema, D. Renal impairment, E. Hypotension. Answer. B. Dry cough. Explanation. ACEs increase bradykinin, leading to cough, 10%. ARBs have similar renal and electrolyte adverse effects, but cause significantly less cough. Q4. LD patient with atrial fibrillation has a CHDS2 VAS score of 3. Which therapy is most appropriate for stroke prevention? A. Aspirin, B. Warfarin INR23, C. Clopidogrel, D. Low-dose rivaroxaban, E. No therapy. Answer. B. Warfarin INR2 to 3. Explanation. Patients with CATS2 VASC2 require anticoagulation. DOACs or warfarin are recommended. Aspirin alone is insufficient. The RX Files atrial fibrillation section emphasizes warfarinox over antiplatelets. Q5. According which thiazide-like diuretic has the best outcome evidence for hypertension? A. Hydrochlorothiazide, B. Indapamide, C. Chlorthalidone, D. Furosemide, E. Bumetanide. Answer. C. Chlorthalidone. Explanation. Chlorthalidone has superior trial evidence, AL-HAT-SHEP, compared to HCTZ. Indapamide is also effective, especially in diabetics, but chlorthalidone is highlighted as the best evidence-based thiazide diuretic. Q6. Which of the following primary target in lipid-lowering therapy as per RX Files? A. HDL 1 mmol per ml, B. Triglycerides 1.5 mmol per ml, C. ApoB 0.8 grams per ml, D. LDL reduction to 50% or 2 mmol per liter, E. Total cholesterol HDL ratio 4. Answer. D. LDL reduction of 50% or 2 mmol per liter. Explanation. Landmark trials show that lowering LDL is the main therapeutic target. ApoB and TC-HDL ratio are secondary markers, but LDL reduction remains the primary goal. Q7. In patients with type 2 diabetes, what is the usual individualized A1C target recommended in RX Files? A. 5.5%, B. 6.0%, C. 6.5 to 7%, D. 7.5%, E. 8.5%. Answer. C. A. 6.5 to 7%. Explanation. Most patients should aim for 7%, with 6.5% in younger, low-risk patients. Less stringent targets, 7.5, 8.5%, may be acceptable in frail elderly or those at high hypoglycemia risk. Q8. Which insulin has the longest duration among the following? A. NPH insulin, B. Insulin glargine, C. Insulin lispro, D. Insulin detamir, E. Regular insulin. Answer. B. Insulin glargine. Explanation. Glargine is a basal insulin with 24-hour coverage. Detamir may last shorter, 16 to 20 orch. NPH lasts 12 to 16 ersh. Lispro and regular are rapid, short-acting. Q9. Which antihypertensive agent is least effective times unless compelling indications exist, e.g. HF-CKD? A. Amlodipine, B. Hydrochlorothiazide, C. Lisinopril, D. Chlorthalidone, E. Diltiazem. Answer. C. Lisinopril. Explanation. ACE inhibitors are less effective as monotherapy in Black patients for hypertension, though still used for CKD, HF, and post-MI indications. Q. Which oral hypoglycemic is associated with risk of hypogal weight gain and is therefore used cautiously? A. Metformin, B. Sulfonylureas, C. DPP-4 inhibitors, D. GLP-1 receptor agonists, E. SGLT2 inhibitors. Answer. B. Sulfonylureas. Explanation. Sulfonylureas, e.g. glyburide, glyclazide, can cause hypoglycemia and weight gain. Metformin is weight neutral. GLP-1 and SGLT2 cause weight loss.